Good morning, everyone. Thank you for starting your day with us bright and early. We're in DG15 discipline session, speaking about emerging topics in CF genetics and genetic counseling. So, unless explicitly stated, opinions shared by presenters do not necessarily represent the views of the CF Foundation. And I'm Kimberly Foyle. I'm co-chairing the session with Katie Singh, and neither of us have any relationships to disclose related to chairing this session or the presentations that you'll hear today. As a reminder for those in our genetic counseling profession, we're going to have a genetic counseling special interest group meeting in this room immediately following this session. So feel free to stick around and join us as a chance to get together while we're all here together in Boston.
So our first speaker is Karen Rere. She's a certified genetic counselor at Johns Hopkins and an assistant professor of genetic medicine. She received her master's in genetic counseling from the University of Maryland School of Medicine, and since 2011, she has been part of the research team at Johns Hopkins involved in the CFTR2 project, the CF Genome Project, and an initiative to investigate the development of a CF-specific genetic counseling service. Her primary interests are genotype-phenotype correlation and the impact of CFTR modulators, as well as communication of genetic information and CF genetics education. She has participated in the writing of several guidelines regarding CFTR testing and CF care, and is the past chair of the CF Special Interest Group within the NSGC. Karen? Oh, yeah, thank you. Yeah, no, I got you.
All right, good morning. Thank you so much for coming out bright and early, as Kim said. I am excited and a little nervous to talk to you about this particular manuscript today, mostly related to the fact that I am a genetic counselor and not a physiologist. So we will not dig too far into methodology here, but we're going to talk about clinical applications. These are my disclosures. I actually think the most important thing on this slide is the bottom one, which is that today's presentation may include discussion of off-label CFTR modulator use. So today's topic and learning objective. This is a manuscript that came out earlier this year. In full disclosure, I'm an author on this manuscript. In vitro modulator responsiveness of 655 CFTR variants found in people with cystic fibrosis. And this particular session this morning have several learning objectives. The one that is mine is to review the process of assessing CFTR variant responsiveness and potential impact on clinical care outcomes with specific focus on newly published data and on variants with and without an approved modulator. So I'm going to start out by just telling you what we are not going to delve into today. This talk is not a comprehensive review of the methodology and analysis used to evaluate the CFTR variant folding, function, and drug response. See above, I am not a physiologist. So if you would like a much more comprehensive look at how all of this was done, I invite you to come to the symposium this afternoon, Update in CFTR Genetics. The other thing that this talk is not going to be today is a critical look at the currently accepted threshold for a modulator responsive variant in terms of FDA approval. I'm going to mention that it's typically right around the 10% threshold of improvement in function. Now, you may have opinions on whether 10% is the correct threshold. That is not going to be part of today's topic, though we'll talk a little bit about what it means to be above or below that threshold. So before I get into the paper, I just want to kind of go through how we think about assessing a variant's effect. So I think most of you know I work with the CFTR2 project, and one of the things that we do as part of that project, which I'll talk about in a minute, is try to figure out how a specific CFTR variant affects a person. And that goes through several processes, right? So we go from gene to protein to cell, tissue, organ, and then patient. And in an ideal world, we would have a genetic variant start at the gene end, and we would have a patient in front of us, and we could study that patient. We could take tissue samples, organ samples. We could do different types of functional testing to figure out exactly what that genetic variant is doing. And sometimes we're lucky enough to be able to do that and actually have a patient in front of us, but not all the time. So sometimes we have to study things by predicting how a genetic effect will impact a protein, and then how that will impact a cell. And if we can figure out what's going on the cellular level, then we can sort of make assumptions about what's going on with a patient. And this is a nice situation for when we have rare variants that are just not practical to study in hundreds of thousands of people on a cellular basis. It's somewhat invasive sometimes to get primary cells from patients. And so we use these heterologous cell systems to help us figure out what's going on functionally. And when it comes to variant leads to function, that affects severity. And then when it comes to therapeutic response, it's been well established that we can see what's going on with a therapy affecting a variant in a cell, and then we think we can translate that to people. So there are a variety of ways that we can study variant function. What we're going to be talking about today is what we consider to be these heterologous cell systems, where we make a variant, put it in a cell, and then extrapolate out to say, this is how we think it will affect a patient. So there's kind of two sides of background here that led to this project. As I think most people are somewhat familiar with, CFTR2 has the goal to evaluate and determine disease liability of different CFTR variants. So we collect data from all over the world, and you may have heard that we have an update now. There's 1,100 variants online. But as part of that, the missense variants, so the variants that lead to an amino acid substitution, those require functional testing because some of them affect protein folding, some of them affect chloride transport, some of them don't have an effect or not an appreciable one. So we have to do that testing, and as you can imagine, that is time and resource intensive. So at this point, as I said, we've evaluated 1,100 variants or so, but we still have 900 mostly rare variants left to evaluate. And these are all variants that have been reported to us from CF registries, clinics around the world. Set that aside for a minute. On the other background slide here, we have the FDA. So in 2017, the FDA allowed in vitro data for label expansion of CFTR modulators. So the initial labels were created from the results of clinical trials where you actually enrolled patients, gave them modulators, and looked at their responses. Now, as I just said before, that can start to get really impractical to actually have a group of patients to study when we're talking about really rare variants that may exist in 1 or 2 or 5 people on 3 different continents. And so at some point, the FDA started to allow in vitro data where we looked at response of drugs in cells and said, well, hey, if it responds in a cell, it's likely going to respond in a patient. And then in 2020, using in vitro data, the approved modulator-eligible variant list increased up to 183 different variants that are currently FDA approved for modulators. And that particular expansion led to about 600 or so, or more than 600 people with CF in the US specifically, who became eligible for CFTR modulators. And so the idea behind this project was that more in vitro data is very likely to be useful in determining who else could respond to CFTR modulators if we could just test more variants. And again, along the way, CFTR2 needs missense variant testing on a baseline level. CFF wants therapeutic testing. And so we sort of married these two things into one project. And so the objective of this particular manuscript, I've condensed this, there were more words, but it's essentially to characterize CFTR variants for their responsiveness to CFTR modulators and thereby identify additional CF-causing variants that could be treated with therapy. Now, I'm going to pause here and just remind everybody, only the drug sponsor can seek FDA approval. This particular study was carried out really led by CFF. They are not the drug sponsor, so they cannot take this paper, take these data, go to FDA and say, here, look what we found, can you expand the label? That's not how the process works. That has to be initiated by the sponsor. However, the hope with publishing this is that, one, maybe nudges the sponsor a little bit, but also that it informs clinicians about rare variants that haven't been tested and maybe now have and might respond to modulators. And that could open the door for a conversation about off-label treatment. So I just have a few slides on the methods. The first is just how we selected the variants to study. So that list came from CFTR2, and it was provided back, I actually had to go back in my emails to see when we came up with this list. It was somewhere in the 2017 era, which was quite a while ago. And so at that time, there were only about 300 or so variants available on the CFTR2 website. There were really only a handful that were modulator approved at that time. Now, since this project started, some number of those 655 variants on the list actually underwent functional testing separate from this project, and some of them got approved for modulators already, which, as you'll see in a few slides, actually works out well to sort of see, kind of how well this data shook out. So this is the breakdown of variant type on that 655 list. The vast majority of variants were missense, and again, those are amino acid substitutions where we really need to figure out what they're doing to the function of CFTR. We did have 33 complex alleles on the list. This is when you have 2 variants in cis, 2 variants in the same CFTR gene, 28 in-frame insertion deletion variants, and then 4 negative controls. So the negative controls are premature termination codon variants, nonsense. I think there was 1 frame shift. Those are variants that we don't expect to make CFTR protein, nor do we expect them to respond to modulators. And so those were in there as a negative control. Now, remember, I said we provided this list in 2017, and since then there was some additional work done separate from this project. And so at this point, of the 655 that were tested, several of them have been tested and made it onto the website, but we still have 460 that are not currently on the website now, even with our 1,100 variants that are available. And then 473 of the 655 tested are currently not on label for CFTR modulators. This is the part I'm actually going to go very quickly through. But essentially, when we test variants in a heterologous cell system, the first step is to make a plasmid. So you make your variant, and you transfect that coding DNA into a cell line. For this particular study, FRTs, or Fisher rat thyroid cells, were used. That's a well-established cell line for studying CFTR. Western blots were performed for protein folding and maturation studies. And then really the kind of the big bang here in this paper was this transepithelial chloride conductance assay, which is called TECC or TEC assay. And the readout from that is called the GT. So if you go and you pull this paper, you see this GT, that's the chloride conductance. And there were 4 conditions tested for each variant. So baseline, that's just how does this variant function when we don't throw any drugs on it? And that's the value that CFTR2 wants to use as our functional testing readout. In addition to baseline, 3 drug conditions were tested. So use of ivacaftor only, use of just the correctors, so elexacaftor and tezacaftor. Now, those correctors alone, that is not an FDA-approved drug, but that was one of the conditions tested. And then the combination of elexacaftor, tezacaftor, and ivacaftor, or ETI. One thing I do want to stress is that the testing done by this was performed blinded at 3 labs. So the CFF Therapeutics Lab ran this project, but Rosalind Franklin University and UT Southwestern were the other 2 sites. Now, I bring this up just to say that the rigor and the amount of work that went into this cannot be overstated. It was incredible to have over 600 variants tested blinded by all these different labs. So the data is really, there's a lot of it. This was a really robust test. The analysis included quality control standards. You got to exclude data that doesn't meet quality control standards. And then all of the data from the functional testing and the Western blots was normalized so that we could present this as a % of wild type. So for CFTR2 purposes, typically % function of 10% or less is what we consider CF causing variants. So we want to see these in a % of wild type form. Metrics were averaged across all of the plates and sites, and there was a lot of fancy math. There's a lot of error bars and things like that that went into this. It was very rigorous. And then lastly, they applied a Bayesian model to determine variant responsiveness to ETI specifically, and then to aid in characterizing variants as responsive or non-responsive. Now, please do not ask me about the Bayesian model. I do not know all the math that went into it. But essentially what this readout is, it takes into account all of the variability in each measurement, comes up with a credible interval that is sort of like a confidence interval. And then you could sort of say, okay, well, if your credible interval is above this 10% threshold for response, then you can call that responsive. So they were able to categorize variants as responsive, non-responsive, or borderline after applying this model. One note, and you'll hear this again, this applies to ETI only. So when you see anything in this paper about a variant being responsive, they're not talking about responsiveness to ivacaftor. They're not talking about responsiveness to just the correctors. It applies to ETI only. So before we get into the results, how do these results actually matter for your patients? Well, if your patient has a variant that's not yet characterized, a rare missense, you may find functional testing information in here, and you may be able to make an educated guess on whether that rare variant is actually CF causing, if the baseline function is below 10%. If your patient has a variant not currently approved for modulator use, you may find drug response information. You may be able to make an educated guess on whether your patient would see clinical improvement with modulator treatment. And that's really the hope that this paper provides. So I'll dive right into the spoiler here. Most of the variants that were tested in this paper do respond to ETI. Let me see if I have a mouse. Can you guys see that? Is that yes? Okay, super. So I'm going to use the trackpad. All right, so this black line here, these black dots, this is a representative subset of the variants tested. It would be a lot to put all 655 on this chart. So these black dots are the baseline function, and they're just ordered in increasing chloride conductance. And so you can see where this is, and function here is on the y-axis. So down here is 0% function, then you go up to 100, 150%, et cetera. So the black line down here, the blue dots up here are those same variants after being treated with ETI, and generally speaking, the blue dots are higher than the black dots. They have more function. So most variants did respond to the drug combination. As I mentioned earlier, the currently accepted threshold for a response is an increase of 10% of wild-type function. And by this rule, 94% of the already modulator-approved variants that happened to be in this study met that threshold. And so what you can see here, again, the black dots, these are baseline function, and we've put a gray square around the variants that fall under 10% baseline function. So these are likely to be CF-causing variants. And then all of the blue triangles are the ETI response in variants that already have modulator approval. And you can see that nearly all of the blue triangles are above that 10% threshold. There actually are a few that didn't make the cut. Now, these are variants that already have modulator approval. This data just suggests that maybe this system worked a little bit differently than the system they were tested in to get that modulator approval. But this was a nice reality check. It's a nice sanity check that all of these variants that already went through a rigorous process, indeed, this system showed a very similar response. Now, the other thing you'll notice about this particular figure is that there's a whole bunch of red triangles also in the responder area. So there were 152 variants not currently approved for modulators that started with baseline function below 10% and went to function above 10% with ETI. And so that's all the red triangles that are in this box. And these are probably the ones that you care the most about. These are very likely to be CF causing, and they are also very likely to have a decent modulator response. Now, as I said, most variants did respond to ETI, but you do have to look at them in two different groups. So overall, about 83% of the variants studied had a greater than 10% wild type increase in chloride conductance, but this varies by their baseline function. And when you separate out two variants with less than 10% baseline function, 68% are responsive. Now, that's still 2/3. It's still a really good number, but it shows us that in that less than 10% baseline function group, there's some number of variants that are probably just too dead to get enough function up above that 10% baseline. So the best way to find this information in the paper is to look at these very large tables. Do not try to read the variants there. They're just all the variants that were tested. So there are three main tables in the main body of the manuscript. This is the ETI responsive variant table. So there were 446 variants listed in this table. And you can see the portion of it that I've put on a screenshot here. These are the variants that had a mean baseline function of less than 10%. Again, that's likely to be the CF causing group. And then they've separated out whether the variant response is in the 10 to 30% range, the 30 to 50% range, or like a really robust response of above 50%. So you can go into the manuscript, do a little Control F and look for your variant of interest and see what table it falls into. So this is the ETI responsive variant table. There's a borderline variant table as well, 117 variants in that, and then a non-responsive table, 91 variants in that. And if you look really closely, and I've highlighted them, the 4 negative controls are in that non-responsive table. Again, really nice sanity check. We don't expect those variants to make protein. We don't expect them to respond to modulators, and indeed they don't. So as I said, this is likely the most accessible way. If you just need a quick answer of what was my variant's baseline function, above or below 10%, and did it respond, do a Control F in the document, see where your variant shakes out. However, if you would like more data or actual numbers or things like that, you have to go into table S1, so supplementary table 1, and this is really the nitty-gritty information, and I'm gonna apologize ahead of time. I'm getting in the weeds a little bit here. However, I think looking at the raw numbers can be really helpful. So in this very large supplemental table that I have screenshots of and that you can download, by the way, I didn't mention this paper is open access, so anybody can get to it. So for each variant, 3 types of data are presented in the supplemental data here. We have variant information, functional data, that's what we're going to focus on in the next few slides, and then protein data. You can get the Western blot data as well for the folding and maturation. As a reminder, 4 conditions tested for each variant. Baseline. Now, when you pull the table, you'll see incubation conditions. I'm going to show you what this looks like. Incubation with DMSO, this is essentially a sort of baseline control. DMSO is just a vehicle, so it's no drug. So you incubate with DMSO, then we test the function. That's just baseline function. Or you could incubate with DMSO and add ivacaftor. That's your response to ivacaftor only. Or we could incubate with the correctors, but not add ivacaftor. That's response to correctors only. And again, there is no FDA-approved therapy that is only correctors. And then finally, incubation with the correctors plus the addition of ivacaftor during the actual experiment. That's the response to ETI. So those are the 4 conditions tested. When you pull up this supplemental table, this is what at least one small part of it looks like. So the variant nomenclature is to the far left. So you have legacy name, cDNA name, protein name. You can search for any of these in the table. This is just the coding sequence position if you want to order it, 5' to 3' for the gene. Also gives you the variant type. And then the allele count. Now, when this paper was published, we didn't have the updated data that went live this week. So the allele count is from the 2023 CFTR2 list. And then this treatment. Now, this is the incubation condition, and this is why each variant in this table is listed 2 times. There were 2 incubation conditions, one with DMSO, one with the correctors. Just as a reminder, and I keep harping on this because it is very confusing to see all the numbers. These are the 4 conditions. Again, you have incubation conditions and acute conditions. When you have DMSO and you don't add ivacaftor, that's your baseline function used by CFTR2. When you incubate with the correctors and add ivacaftor acutely during the experiment, that's the ETI response, and that's the portion that underwent that Bayesian analysis to determine whether things were responsive or not. So I have a couple examples. When you go through the rest of the table, there are a lot of columns of data to look at, and I've pulled out the ones that I think are the most important. So these normalized conductance GT mean values, remember I said GT, that's the readout from that tech assay, that's the functional testing result, and this is all in % wild type. And then there's a column that actually looks at the ETI responsiveness. And I'll remind you again that borderline responsive, non-responsive, that is related to ETI only. It does not matter for ivacaftor. It does not matter for the correctors. It's just ETI. So what does this look like for an individual variant if you want to go through this table and search yours? This is G27E, missense variant. It's rare. It has 0.75% baseline function, so less than 1% baseline function. When you add ivacaftor, and you can see, so here's this, FSK is forskolin. That's how we activate CFTR, so we can measure its function when we then inhibit it. So forskolin response as a % of wild type, that's your baseline. And here's forskolin plus ivacaftor in the experiment as a % of wild type. So we start at 0.75 baseline function. You add ivacaftor, you go up to 1. I would guess if I pulled the error bars from this is probably not statistically significant, maybe a teeny tiny bump, but I'm guessing not. When you incubate in the correctors, though, even without ivacaftor, suddenly you're at function of close to 40%. And then when you add ETI, you're actually at function now of 44% of normal. And so the 2 values that I think are most useful to look at are this upper left value of baseline and the lower right value of ETI. And those are the 2 values that were compared to determine that this is a responsive variant. Now, this one's fairly obvious. You go from 1% to 44% function. I think everybody agrees that's a pretty darn good responsive variant. Here's one that's a little bit less clear. This is actually one of the complex alleles. So L15P in cis with L1253F. Baseline function just over 1%. I'm going to skip the other 2 and just go straight to ETI function, 12.45%. And so you say, well, Karen, you told me the threshold was 10% and 12 is higher than 10. What's going on with calling this borderline? This is where that Bayesian analysis comes in. And if you want, you can delve deeper into this table and pull the error bars associated with all of these values. And what you'll see is there's some overlap with that 10% threshold. And so basically the math says we can't tell for sure that this is definitely a responsive variant or definitely not. So we're going to call it borderline. Now, from your clinical perspective, just knowing that it's a borderline response may not actually be that helpful if you just go into the tables in the main manuscript. But if you pull this data and you say, well, 1% function up to 12% function, hey, maybe that's enough to consider trying a modulator in my patient. I'm not telling you to do that. I am not your clinician. But I'm saying these are the types of conversations that you might be able to have if you look at these raw numbers. Now, here's what a non-responsive variant looks like. This is W57G. Baseline function, 0.75%, so under 1%. Very likely this is a CF-causing variant. With ETI, you get it up to 5%. Now, that does not come near the 10% threshold, even with credible intervals and things like that. So this is a non-responsive variant. However, I would say again that looking at the numbers might be helpful. We know when we think about functional level and phenotype that when you get into the 3, 4, 5, 6, 7% function range, people tend to have pancreatic sufficient CF. And maybe this is indicating you could go from 1% function to 5% function. It might not be. You might have to look at the error bars. But I think, again, this could stimulate a conversation, at least. Or you could say 1% to 5%. That's nothing. I don't think we're going to see clinical improvement. So I just wanted to sort of show you how to navigate this table, because I think that it provides a little bit more granular data than just looking at the responsive, borderline, non-responsive. So I'll end here with just 2 more points. So a quick reminder, your clinical assessment matters. Now, the function that's determined by the TEC assays correlate well with previous studies, but there are outliers. So in this table, or in this chart here, this is the TEC measurement, so percent of wild type on the x-axis. This is on a log scale, so 0.1, 1%, 10%. Same log scale on the y. These are chloride conductance studies from other systems. Remember I said when we provided this list, a handful, actually about 200 of those variants were also tested in other systems and then determined to be CF-causing or VCCs. Here's the results from those other systems, and I've put the lines in at 10%. So in this box here, we have CF-causing variants that were under 10% function in the TEC system and under 10% function in other functional testing systems. But here, we've got a couple that were under 10% function in other systems, but above 10% in this particular assay. And that can be for a variety of reasons. It does not mean that the data's bad. Sometimes there are differences in cell systems. But what I want to make sure of is that you don't go look at a variant and say, oh, it's got 80% function. My patient must not have CF. If your patient has CF, your patient has CF. There can be other reasons that they have a variant with high function. So your clinical assessment matters. And I probably don't have to say that to this group, but I'll say it anyway. Now, why might there be differences in function and phenotype? Why do you say, well, I have a patient in front of me, they're sweating 100, they're pancreatic insufficient, they clearly have CF, but you tell me their variant has 80% function? Couple reasons for that. One, there always could be technical problems with the assays. That's not unique to this study. It happens in our lab. It happens in other labs. But there's also 2 other things. So you could have a missense variant that's impacting splicing. This type of assay is not going to assess splicing, so you won't find that. So you could consider looking up your variant in a splicing algorithm. I will say that if variants are predicted or known to affect splicing, that's noted in the manuscript, so you can go looking for that information. Now, the other option is in-cis changes, so complex alleles. They may confound things. If your patient, in fact, has a complex allele and you're only looking up the function of one variant, go look up the function of the complex allele. See if it was tested. That'll give you information. Or if your patient doesn't have a complex allele that you know of, go look in the literature. See if it's been reported as a complex allele. Maybe your patient needs additional genetic testing to find out if there are other changes. So what's next with this? So the CFF therapeutic lab is actually continuing to test another 250 or so variants. That was a list from the new CFTR2 data set. We are underway with analysis of the functional data generated here and preparing a manuscript that's going to describe how we can use these functional results to interpret variants on CFTR2. So I'm hoping in the next year we'll have another batch of a couple hundred that can be interpreted using this data. And then, of course, obviously, these data hopefully will inform at least conversations with providers, but maybe also label expansion. Again, not something the authors here can do, but now the data's out there, and increase access to modulators for individuals with CF. So I'll just end there with a lot of acknowledgements. The whole cutting lab and team at Johns Hopkins, CFTR2 team, the CFF missense group that thinks very hard about the physiology behind some of this and molecular effects. Lots of collaborators at CFFT, UT Southwestern, Rosalind Franklin, University of Bristol, Vertex, and Emory. I talked longer than I thought. Now I have 2 minutes for questions.
No, that would be fine.
Oh, great. Okay. And this QR code, if you want a direct link to the paper, you can scan that. Like I said, it's open access.
Oh, good. I thought that was my question time.
Okay. Well, I talked faster than I thought.
I'll check the app.
Yeah, we have time for questions. We'll check the app and feel free to come up to the mic.
And also, there are some chairs in the front if anybody who's standing wants to sit.
Not a question, but a comment. I used this paper recently in a newly diagnosed patient who had just moved to the US, and we got modulator approved for him. He had very rare variants, consanguineous parents, and he's responding well.
Oh, I'm so glad to hear that.
thank
That's really wonderful
Yes.
news.
It's also not a question, but rather a comment. I'm Isabelle Samet from Paris, and we initiated the French Compassionate Program based on the primary cells with a multi-center study. And I just want to say that we really had patients with primary cells responding between 5 to 10%. Actually, that was the first patient. The 0 patient was a R334W and responded at 7%, and she had main clinical response. So I would really advocate not to reject those beyond 10%, but really consider those between 5 and 10%. And I also really support what you said about the splicing mutations. So in our ERG paper, we showed 2 patients with splice site mutations at the end of the gene, and we really dissect the mechanism. So those are really very, very interesting to further understand also the CFTR structure and what is really important for CFTR function or not, and for the clinical response of the patients and the chloride transport. So thank you.
Thank you for your comment. And yeah, now that I'm not officially part of the talk, I'll give my own comments. So that I feel really strongly that people do need to look at the raw numbers, because to your point, if you can take somebody from 1% function to 9% total function, does that get you above a threshold where we think you don't have CF? No. Does that get you to a function that's associated with less severe disease? Yes, it does. Now, I'm not saying that will happen in every patient. It definitely won't. But it could in some. And so I think what is really important is to try to dig into the data here. If you have the capacity to dig through that very large supplemental table, this is where I think the raw data can be useful. And of course, these cell lines are not people. So we know that there's a pretty good correlation between what we see in cell lines and what we see in people. That has been well established. But I said it's a pretty good correlation. It's not perfect, right? There are tissue-specific effects in people. People have other genes and other things going on that impacts their phenotype and impacts how they respond to drugs. And so this, I think, is a really nice guide. But again, I think you need to take it in context of your patient and think about, what are these improvements in function and things like that. So I thank you so much for that comment. Yeah.
It's telling us there are no app questions, so if you submitted an app question, that means it's not working. Raise your hand.
So either I've solved it or I've confused everybody so much that nobody wants to touch it.
I think you explained it so well. I
It's
tried
a
to come
really
up with a
tough paper.
question and I couldn't.
No, it's a very dense paper, and I have a lot of gratitude for the group at CFFT that did really all the heavy lifting, and not me. So thank you so much for the invitation today.
Thank you.
Okay.
Thank you, Karen. And next we'll switch gears. I'm pleased to introduce Dr. Sylvia St. Petery. Dr. St. Petery is an associate professor of pediatrics and a pediatric pulmonologist at the Medical University of South Carolina. She serves as the Pediatric CF Center Director. She received her medical degree from Tulane University in New Orleans, went on to complete her pediatric residency at the University of Virginia and her pulmonary fellowship at the Children's Hospital of Pittsburgh. Her primary areas of interest include prenatal treatment of cystic fibrosis-related complications and the evolving nutritional status in the modulator era.
Thank you.
Good morning, and thank you so much for the introduction and an opportunity to be here and share some data about prenatal treatment of cystic fibrosis. I have the following disclosures to mention: a research relationship with Vertex Pharmaceuticals, and then quite detailed discussion of off-label clinical use of CFTR modulators. My goal today is to summarize a combination of medical outcomes related to this prenatal off-label CFTR modulator use in fetuses with CF, and also to discuss some logistical considerations, not only in how patients have been treated up until the present day, but also what we might consider moving forward and how to optimize pathways and which patients might be the right ones to consider treatment for. So you all know a great deal about cystic fibrosis if you're attending this conference, but I like to give the context that the initial diagnosis was made by a thoughtful pathologist back in the 1930s, and this disease was quite different at that time. Children lived only weeks to months. It was really a characteristic finding of the pancreatic effects of disease that brought this diagnostic condition to attention. And we, of course, know the inheritance patterns that are autosomal recessive, but that there can be some complexities to the diagnosis itself. CFTR function, this is a channel that regulates airway fluid ion composition, and the clinical symptoms that we see related to this typically are manifested by that alteration in salt content. And we know that it plays a significant role in multi-system effects of the GI tract, the respiratory tract, the sinuses, the reproductive tract. And so all of this can have significant effects for many different folks in many different systems of their life. When this first came to attention, again, infants were living months, perhaps a year of life when the 1940s brought this to attention. But what we found over the interim decades is that by attending to first symptoms, creating organizations around the study of cystic fibrosis, and then having more targeted therapies, mortality and morbidity has improved quite dramatically. And so for folks who were born before 2019, their median survival is about 57 years. But what we also know is that for folks who have been born 2019 forward, they actually have a median survival of 61 years, which is marching closer and closer to the median survival of the average person in the United States, which I think is quite remarkable. What I'll focus on for the remainder of my talk is a series of cases. So we have 9 infants who were treated prenatally between the years of 2021 and 2023. 2 mothers had their own known cystic fibrosis diagnosis before pregnancy, and 7 mothers were carriers. The infants born to the 2 CF mothers had the genotypes of F508del 5T12TG, and one was F508del homozygous. And 5 of the carrier mother infants were also F508del homozygous, with 2 other infants having 1 copy of F508del and 1 copy of W128X and R553X. Among the mothers with CF, their own mutations were F508del 2183del AA to G and R117H5T12TG. Among the carriers, majority had 1 copy of delta F508, 1 had 1 copy of R553X, and among the fathers in the carrier group, the majority had 1 copy of delta F508, and 1 had 1 copy of W1282X. In regards to diagnosis, 2 of the families had the insight of a prior child with CF, so they were much more attentive to the consideration of a future child with this diagnosis. 78% or 7 of 9 pregnancies had a diagnosis via amniocentesis. The mean gestational age at diagnosis was just under 19 weeks. 6 of the 9 infants were found to be F508del homozygous, and just over 50%, 5 of the 9, were female, with the remainder being male. What I think is quite important for this group is that all families had insurance. The type and variety of insurance is quite varied. So some had variations on Medicaid, Florida Blue Plan. Some had TRICARE, which from personal experience as a clinician has been somewhat easier to work with in regards to having CFTR modulators approved. And then the remainder had a variety of different, more private insurance carriers. But we'll talk about more of the details of their obtaining drug down the line. The mean maternal age was just over 31 years, and all parents reported a Caucasian race. 89% of the pregnancies were characterized as having an abnormal prenatal ultrasound, and this was, for many, the impetus behind considering ETI. The initial abnormal ultrasounds were identified anywhere between 18 weeks and 29 weeks, with the majority having a characteristic finding suggestive of meconium ileus, including some echogenic bowel or dilated bowel loops, with one having a frank finding of this is meconium ileus, do not pass go, this is the only thing this could be, and one finding of polyhydramnios. The mean gestational age at the discussion of treatment initiation was a few weeks later for the average infant, so closer to 22 weeks. One patient, again, because of mom's diagnosis of cystic fibrosis, was already on ETI herself. So the treatment really was more, do we continue this? Is there anything we should consider as an alteration or change in path? 11% of patients discussed this in relation to an adult care team visit. 11%, this was brought up by their OB or MFM at a routine or subsequent follow-up visit related to the ultrasound abnormality. 33% of patients, or 3 of the 9, this discussion was initiated with their pediatric care team. And 44% of parents actually said that it was they themselves, with discussion in any of these other care groups, that initiated the concept of, would we want to start ETI to treat these ultrasound findings or disease in the fetus. Of those who actually placed the prescription, what I find interesting is that the majority of this was through the pediatric care center providers. So for this pathway to be functional, that means not only was this identified in the maternal fetal space, but then there was a referral to a CF care center, probably with some inclusion of the adult care center as well, and then pediatric care center provider being identified for the future infant, and then the prescription originating from that clinic. 33% did come from the adult care center provider, so it's possible that that may be a feasible pathway as well. For the prescriptions themselves, I was relatively encouraged by this, that 44% were approved on first pass, so that there was not a extended delay in drug delivery. 22% did have an appeal. These appeals can sometimes be lengthy, so insurance companies can take sometimes up to 30 or 40 days to respond. And so we'll talk about that a bit more in the lag time between prescription and drug delivery. There was one case that required a peer-to-peer, so that means that after that appeal of anywhere from a handful of days to 30 days, then there was some other lag time in coordinating that discussion between the insurance company and the care team. And then one patient did have the previously approved ETI for their own cystic fibrosis. So when we look at the ultrasounds in a broader view, we have a first identification just under 19 weeks of echogenic bowel, and the latest diagnosis of an ultrasound abnormality just under 33 weeks with the finding of polyhydramnios. For the bowel findings specifically, those ranged anywhere from the just under 19 weeks to 29 weeks gestation. ETI initiation then varied somewhat across those groups. So for the pre-pregnancy person, we'll sort of scratch them off the list, but ETI was able to be started as early as 24 weeks and then as late as just before 32 weeks for this group of patients, with findings on the initial ultrasound having resolved on subsequent ultrasound anywhere from 32 weeks to 39 weeks. And if we put all of this together, on average, abnormal ultrasound findings occurred just after 22 weeks. ETI initiation occurred just under 3 weeks after that ultrasound finding. And then from the ultrasound finding to ETI prescription, resolution occurred at approximately 6 weeks on average. So 6-week treatment time on average, but a minimum of 2 weeks, which I think is quite impressive and striking, and a maximum of 15 weeks, which is a pretty broad spread of timeline. Delivery, on average, these babies were delivered at term, 38 weeks and 6/7, but a range from 36 and 1 to 41 and 4. The 2 infants that were late preterm were both delivered at 36 weeks and 1 day, and the average of the term infants was 39 weeks and 4 days. All infants were vigorous. There were no major delivery-related complications. 3 did require a cesarean delivery for a combination of factors, whether that was a breech or some indication of fetal distress. 2, again, were late preterm, and there was 1 pregnancy that was complicated by preeclampsia, which then resulted in a cesarean section delivery. 5 of the infants were admitted to the NICU. My clinician eye tells me that some of these were likely not required, and I can share for the infant that we cared for at our center that it was really out of an abundance of caution. There was 1 late preterm infant that had obvious symptoms, so poor feeding, recurrent vomiting, and the requirement of feeding through a nasogastric tube. Of the term infants, 2 were just brief observations. This was really for ensuring that no signs of meconium ileus or stool passage issues occurred, and those infants had no issues. 1 had a sepsis rule out, so had blood cultures drawn and was observed for 48 hours to ensure that those remained sterile. And then 1 infant did have some signs of meconium ileus, a delayed meconium passage, and the requirement of a barium enema administration. All infants did have typical state newborn screening completed. Their immunoreactive trypsinogens were on average technically elevated for most states' algorithms. That is a quite varied approach, and I can't speak to your state. Be happy to give suggestions afterwards, but the range was quite broad, from 35.7 to 201.8, which for many states falls into that ultra-high characteristic. There were 3 noted to have a negative newborn screen, which I think is an important consideration. And those 3 infants had the genotypes of F508del homozygous, F508del R553X, and F508del 5G12TG. What I find additionally interesting is that those 3 infants who had negative newborn screens went on to have only 2 of 3 with positive sweat tests. So the 2 positives were in the 60 to 67 range, 96 to 95 range, and then 1 was 23 and 23 with the genotype of F508del 5T12TG. However, there was 1 infant who had a positive newborn screen with an IRT of 96.8 and on repeat 201.8, whose sweat chloride was 39, which is firmly in the intermediate range. On average, the sweat chloride across the group was 69 millimoles per liter, which is really just crossing that threshold of being diagnostically positive, which I think is very interesting. And I'd be quite curious, we don't have this data yet, but in this group of infants with ongoing ETI exposure, their sweat chloride, I anticipate, is probably drifting down over time. And so as we get more data moving forward, it would be interesting to see how that changes. In regards to feeding, 7 of the 9 infants were breastfed, and they did as a consequence of their mothers choosing to continue ETI treatment after birth. had ongoing ETI exposure. The fecal elastase on average of those breastfed infants was 259 micrograms per gram, which is for most labs in the normal range of pancreatic sufficient status. 2 mothers chose to withdraw ETI for a variety of reasons, and the mean fecal elastase in that group was 16 micrograms, or very clearly pancreatic insufficient. 4 of the infants were initiated on empiric pancreatic enzyme replacement therapy, which is a practice that many clinicians start from birth. 2 infants did not receive further ETI via breast milk, and so they were found to ultimately develop pancreatic insufficiency or were born with pancreatic insufficiency with fecal elastase of less than 20 micrograms per gram. But 2 of the infants continued to receive ETI through breast milk. 1 developed clear pancreatic sufficiency with fecal elastases above 400, and so was able to stop PERT. And 1 is continuing to have increasing levels of fecal elastase in the range of 100 to 150. And so that infant is continuing to be monitored as to whether perhaps their need for PERT is resolving. For those who did receive ETI via breast milk, at least transiently, we have encouraging data about their pancreas function improving. But for those who discontinued, these occurred for a couple of reasons, with 2 mothers stopping ETI within that 3 to 4 weeks of life. 1 unfortunately had insurance challenges and so just simply couldn't get drug any further. And 1 infant had otherwise unexplained, unconjugated hyperbilirubinemia, which we truthfully can see in cystic fibrosis in the absence of any other of these confounding prenatal treatments. But the family chose to discontinue ETI because there were no other reasons that they could explain it. And so what I think is helpful to note is that of those infants who received ETI via breast milk, the majority of those were pancreatic sufficient at some point in the first year of life. This is breaking it down by genotype. So 4 of those 5 were F508del homozygous, which is, again, quite uncharacteristic for that genotype. And 1 had the genotype of F508del 5T12TG. All infants had additional lab monitoring after delivery. Most had a smattering of AST, ALT, bilirubins, some direct, some indirect, GGT and alkaline phosphatase measured in some frequency. This varied across each center, and some had these labs as often as once per month, but on average it was typically about once a quarter. There were some mild derangements in these labs, but many were normal, and none typically raised above the threshold of 3 times the upper limit of normal for age-appropriate values. There was 1 infant who had serial lipase monitoring later in infancy, and this was during the ongoing period of breastfeeding ETI exposure. This did reach a peak that one would consider suggestive of pancreatitis, but the infant had no symptoms. And so this was just trended over time and monitored without any intervention. And then again, there was the single report of unconjugated hyperbilirubinemia leading to the early discontinuation of ETI in the first few weeks of life. All infants also had ophthalmologic monitoring. All were normal without any cataracts. And these ranged quite broadly across the first year of life from 16 days to 9 months, with a mean of about 4 months. Overall growth in the group was reassuring. So the percentiles reported by the providers caring for these infants were not adjusted for prematurity, which is bringing the lower range of values down somewhat. So 2% at the minimum for the late preterm infant, up to 99% for one of the term infants with a mean of 37%. For weight, length had a similar distribution with a mean of 42%, and weight for length was really right at the 50th percentile, which is what we would expect for an average group of infants. And truthfully, maybe a bit more robust than we would expect for an average infant for CF, or at least what my clinical experience has been. In regards to therapy transitions, that is an ongoing piece of discussion across these prenatally treated infants. When, how, what drug. 4 have transitioned from simply receiving drug through breast milk to taking a CFTR modulator orally themselves. And this was initiated anywhere between 4 months and 20 months with an average of 10. 2 are prescribed age-appropriate, label-approved drugs. So this would be Lumiva for those under age 2, which this group still comprises that age range. 1 is receiving maternally prescribed ETI, since they were not able to or did not pursue a prescription for the infant directly. And then 1 is receiving early access insurance-approved ETI. So what I think this really gives me as takeaways is the consideration of modulators as prevention of disease. We've seen that this practice is increasing in carrier mothers across the US and also internationally. I think this case series specifically reflects that meconium ileus, or findings suggestive of meconium ileus, can be rescued by using ETI prenatally. We know that across a variety of different insurance providers, this prenatal treatment is being approved, which I think is encouraging. But as I mentioned, with one family having a barrier to continuing ETI post-delivery, it's not without its difficulties and barriers. We also know through reports both in the US and in Europe that vas deferens preservation in male infants has been identified in a small number of patients. And so this really has some far-reaching implications on fertility in men with CF. And when I think of counseling patients that I'm meeting in the newborn period, one of the things that ultimately we do discuss is that it can have significant effects on fertility, both for males and for females. But for males, the almost knee-jerk response of infertility, I think having that conversation potentially change may be something that many families are interested in considering prenatal ETI for. So to conclude, again, this is a practice that's increasing both among carrier mothers and among mothers with CF. Disease hallmarks of cystic fibrosis, including pancreatic insufficiency, meconium ileus, and then fertility considerations are of a high interest in this prenatal treatment context. I think the implications on newborn screening are quite important, in that knowing that an infant treated in this way may have an abnormally or a falsely normal newborn screen result, that will require coordination at a center level and a state level to make sure that the appropriate testing is completed for these infants. Prenatal counseling, I think, also is a huge piece of this puzzle, and considering what's the right choice for a given family, a given scenario, all of that will require a coordinated effort. And to that point also, testing considerations and how we identify these infants, I think, is also an evolving process. Overall, I think there's a greater need for significant data to determine how is this in terms of safety, efficacy, and how might we apply it among different scenarios, males, females, et cetera. I think all of these are really important questions to answer. And so I'd be delighted to take any questions or comments that you have about this case series.
Please feel free to come to the mic if you have questions.
Hi, I'm Sumeda from Green Bay, and I think this is a really unique role for genetic counselors. I'm a CF GC embedded in a pediatric and adult CF clinic. I also work with the prenatal population and our maternal fetal medicine team, and I'm also a pediatric GC. So it's really nice for my team because I can bridge the maternal fetal medicine arena, and then I can bridge the post newborn screening with the pediatrician and guiding the monitoring. So I think it's a really unique role for genetic counselors. Thank you so much for your presentation.
Thank you.
Thank you. So I'm Isabelle from Paris. So the French guidelines for the moment for these cases is to administer ETI in utero. And then we stopped. We decided to stop breastfeeding, not to allow breastfeeding, because there were reports that the dosage and the level of ETI in breast in the milk was quite low. And on the other side, we are aware of all the liver function abnormal tests, and you also highlight pancreatic, actually biologic pancreatic. So I am really very much interested in what you described, that you may avoid or decrease the level of pancreatic insufficiency. So my first question is, did you assess the level of ETI in breast?
No, so unfortunately, this group was all clinical decision-making treatments at individual institutions. What I think would be very interesting is moving forward if we were able to develop a cohort that we could follow prospectively. I think we have the capacity to measure ETI in breast milk and the capacity to measure ETI in plasma for infants and mothers, and there's a variety of ways we could approach it. But I do think that we know that there are so many factors that go into how much any drug can pass into breast milk. And so we get the sense that what's passing through the breast milk is enough to have some positive effect. But for some infants, they may be receiving a very different dose effectively than another. And so does that mother need to take as much? Would that then lower the risk of the drug effect itself? And how might we tailor that to be more person-specific and case-by-case specific? So I think in a perfect world, we would absolutely be able to monitor and measure the effective dose that the infant is receiving. So I'm hopeful that that will be part of a future study, but it's not something that we have data on currently.
And my second question was for the early access to ETI. So how old was the infant?
So I believe the prescription was started at 6 months, so under a year.
And would you share the dosage that you...
Yes. So for every infant that we've treated, both in this case series and separate from this case series, we've taken the component of ivacaftor that's weight-based and used that to identify a corresponding ETI dose. So we take the ivacaftor component that's down to age...
5 milligram per kilo, more or less, yeah?
Right. And then we essentially just do a little bit of math. If the infant is below that weight or below that age, I think reducing it by half is what we've done in one infant that fell in that age group. And we've had great success with our clinical pharmacist in identifying how many granules are there per packet and counseling the family on how many granules to give per day based on that weight-based percentage of the dose.
Thank you.
But I have a graph, a table. If anyone were to need it, I'm happy to share that.
Very much interested.
Yeah, absolutely.
Hi, Charlotte Close. I'm a pediatric genetic counselor. You might not have this information, so it might not be the child that you treated at your center, but I'm interested how the conversation went with the family that had the F508del 5T12TG and how the decision-making sort of went prenatally and postnatally.
Yes, so lucky for you, that child was at our center. What makes it quite, what made the decision-making, I think, more straightforward was mom has CF. Okay. Mom had not been taking a modulator pre-pregnancy. She was generally doing fairly well, but I think the decision-making that really cemented that choice for her was the potential for vas deferens rescue. And I know that the data on that is still very much, small case reports. I think we've only had one that included 2 and one that included 1. But the possibility of that was enough to convince her that, yes, this may help me in my own pregnancy and maintaining my respiratory health during what might be a stressful period.
She had R117.
R117H, 5T12TG.
Wondering if she had another.
Yes.
And then do they continue it postnatally?
Yes.
Okay, interesting.
Hi, Angel Zaravini from Joe DiMaggio's in Florida. But kind of a similar question. I actually was just approached by a genetic counselor where they have a CF care team, but there's not really a great connection. And she has a mom that has a variant of varying clinical consequences and a disease-causing variant. Mom is interested in navigating that conversation of modulator therapy. How would you speak with her about that in navigating if that is a possibility, or is it kind of more clear-cut to disease-causing?
So this is a difficult question. I think one piece I would have is, would drug be potentially able to be approved? From just a logistical standpoint, how difficult would that piece be? And considering the stress one might cause of saying, we think that this is possible to prescribe, but it might be challenging to actually get in hand, versus the sort of combination of unknowns of the genotype and not knowing if the genotype would truly cause disease. How would that be measured and monitored? I think a helpful illustration is for the infant we were just discussing, the question of whether or not this infant would have been well in the absence of prenatal ETI exposure and not had any declaration of disease after the newborn period, versus now the scenario being that we have to assume that the infant would have had disease and it is being masked by maternal ETI intake and continued exposure through breast milk. And what tests can we do after the baby is born to see, are there any subtle signs? And once an infant weans from breast milk, then what do you do? Do you continue to treat? Can that be achieved by the infant's genotype with securing their own prescription if that were the choice of the family? I think there are many unknowns in that picture, but I think that it's something that certainly most centers would probably be open to discussing, but I think that it really adds a layer of complexity and unknowns, not only in would there be ability to get drug access, and then how thoughtfully would that have to be approached after delivery to consider weaning, consider additional monitoring that in theory the baby may not otherwise have been getting, and how much are you medicalizing an infant that might have been well? So it's really a difficult decision.
Okay, thank you. If anyone's-
So at a minimum, they had the Trikafta level monitoring of quarterly transaminases. I believe all mothers had what we would consider to be standard of care mental health assessments of prenatal and early post-delivery anxiety and depression screening. But beyond that, it was more center to center in terms of they had more aggressive monitoring or other additional labs outside of the typical standard of care. I think in the setting of the obstetric-focused testing, they would have had more frequent ultrasounds because of their abnormal prenatal ultrasounds. But outside of that, it was just specific on a case-by-case basis.
There's a related app question asking if there were any reports of adverse effects in those carrier moms from that monitoring.
So outside of one report of pre-existing anxiety and depression pre-pregnancy and continued symptoms of anxiety and depression during the pregnancy and I believe after delivery, there were no specific concerning side effects that were reported.
Another app question. There were 8 out of 9 fetuses with ultrasound findings and 1 parent on ETI at conception. Curious, was the fetus without an ultrasound finding the child of the mother with CF?
Yes.
I had a question about the ultrasound findings. The polyhydramnios, do you think that's related? I couldn't think of a I don't work in prenatal.
I'm not sure. So what I have learned in clinical practice is that I should remain humble and open-minded to all things, and that CF is a very gray disease that has many manifestations that I might not necessarily expect. One thing that comes to mind specifically is that you can have CF-related like pseudo-Bartter syndrome and renal effects and kidney disease that, to be honest, is not my forte. But it did resolve, and the infant was born and had a generally benign course. So it's hard to say if might that have been the infant that was delivered at 41 weeks and maybe a bit of macrosomia. Not sure.
All right. Go ahead.
Just regarding potential adverse effects, do we know how quickly funding is or studies are moving forward with either animal models or anything like that? Because I feel like that data is going to be really important.
That's a great question. I don't have a specific answer about animal models. What I can tell you is that as part of a working group, we're going to be meeting in November to try to carve a path forward for how we can approach this with consideration to all of the discussion points that we've talked about here today. And so I'm optimistic that we'll have a research plan hopefully by the end of the year. But outside of that, no specific answers for a project yet.
So we're going to do one more question from the app for the sake of time, and then we'll open up Q&A for all of our speakers if there's additional time at the end of the session. But this question asks about pediatric screening for cataracts based on our cases presented with no cataracts in ETI-exposed infants. Should children without CF born to mothers with CF and thereby prenatally exposed to ETI be tested for cataracts?
I would. So what I find interesting is that there was a case series of 3 infants who were identified as having cataracts in ETI, the setting of ETI exposure, published by Raksha Jain maybe 2 years ago. And if I remember correctly, all of those infants were non-CF infants, presumably of CF mothers. I think we'll have more data from Mayflowers hopefully soon that may be able to give us more context to that. But I think that there may be some metabolism differences or additional risk factors for non-CF infants versus CF infants. But I think if even in a CF infant or child, the recommendation is to screen for cataracts, I think as long as that infant is being exposed at a minimum, if they're continuing to breastfeed, I would get a newborn exam and then probably at least a first couple of years of life. But I don't think it would be unreasonable to screen, biannually for the entirety of that child's childhood years, since we know that risk apparently magically stops at age 18. So my conservative answer would be to screen regularly, yes. Thank you so much for the questions and attention.
It's my pleasure to welcome our last speaker, Dr. Dan Dorgan. He's an adult pulmonologist and the Associate Program Director of the Adult CF Program at the University of Pennsylvania. He is the site director for University of Pennsylvania within the TDN and also serves on the CFF Data Safety Monitoring Board. He's been the site principal investigator for a wide range of clinical trials in CF. And you want the newer slides, right? This one. Yeah, sure. Thank you.
All right, yeah, thanks, Katie and Kimberly, for inviting me to speak. Thank you all for being here and giving your attention. Of course, this is a really broad topic, but I will do my best to fit what I can into 30 minutes. My disclosure slides are essentially, I've been the site PI for many trials, but relevant to this talk, 40MT, Translate Bio, and Spirovant. My general take is what I care about is what's going to work in the end, not which studies I happen to be a site PI for. just this icons remind me, I often see people taking pictures of slides. If you are interested in slides that don't have the back of somebody's head in the picture, please feel free. Like, I have a book up here, come introduce yourself, write down your email address. And because then also I like to tell my stories in pictures. So then if you're like, wait, what the heck did this slide mean? Then you can also like have an email exchange with me to be like, can you remind me what slide 10 was all about? So please feel free to come up and give me your email address if you want slides. So now the aim of this talk, I kind of like the saying, the further you get from the shore, the deeper the water gets. So when discussing genetic-based therapies, there's so much deep water you can get into. You could probably expand individual slides in this talk that I'm giving to an hour talk in and of themselves. So I'm going to try to give a broad summary overview of genetic-based or nucleic acid-based therapies and drug development pipelines, and really focusing on what are the things that are in the phases of human clinical trials, so when you're talking to patients, you can kind of give them a context for where things stand now. But I don't really have the space in this talk to go into real depth on any specific treatment. So I think everybody here knows the central dogma. So DNA transcribed to messenger RNA and then translated to produce protein that then is trafficked to where it needs to go. So this is showing that in the context of CF specifically, creating CFTR protein, and then ideally a functional CFTR channel sitting in the cell membrane to traffic chloride and bicarbonate from inside the cell to outside. And again, this is something I think everybody in this room probably knows this. CFTR modulator therapy is not a genetic-based therapy. The reason I bring this up is just because we still have some patients who are confused about this point. And I like to think about, well, why might people think that? And I think part of it comes from the idea that's like, wait, so you're saying this therapy is appropriate for me based on my gene, but it's not genetic-based? And so I think it's just that you know, our terminology just kind of trips people up in terms of what this means. And so showing this in a cell diagram, it's really just, okay, where are CFTR potentiators and correctors working? And so we have our central dogma where we have DNA to messenger RNA to protein, and really the correctors and potentiators are acting at the level of the protein after translation. So trying to, it still might be hard for somebody who doesn't have a scientific background when you're trying to explain to patients saying, you know, yes, it's based on what gene mutation you have, but it's really acting at the level of the protein and not on the gene itself. Showing it back in the simpler picture. So the correctors are happening in the cytoplasm after the protein is made, and you have an unstable protein that wouldn't traffic to the cell membrane, so the corrector stabilizes it, and then the potentiator acts when the protein is sitting at the cell membrane to get that channel to open so that chloride can go through. Here's just another picture, which honestly, I think I've already conveyed this message, but I just find this to be a beautiful picture, so I couldn't leave it out. But so this is showing wild-type CFTR on the left. I think I'm probably just amazed by the fact that we have the resolution to really get the structure of what's happening with proteins after translation. And so then F508del in the middle, where you can just see the shape of the protein is different. The attractive forces between different amino acids are not working correctly, so you have an unstable protein, and that's what breaks down. And so then on the picture on the right, showing where alexicaftor and tezacaftor are binding into that protein to then get the shape of the protein back to what it should be, and then ivacaftor also sitting there to act as the potentiator. And then, so when we're talking about genetic-based therapies, we really mean at the level of genetic therapy or the genetic information. So whether it's at the DNA level or at the RNA level. So it's just kind of the other half of this diagram. And I think part of this is where it's more of a mouthful to say nucleic acid-based therapies, but probably a little bit, it provides some of the clarity in terms of what we're talking about, that the therapy itself is using nucleic acids. And so that again, it may be something where a layperson may still struggle to understand what we mean by that differentiation. But I'm seeing this more and more in the literature, people using NABT as the term. And so why do we need these? So again, I think most people in the audience are familiar with the idea that CFTR modulators are not for all mutations. I mean, Karen's talk was getting into that. And then there's side effects, intolerance of some of the modulators for some patients. There's the idea that there's daily dosing. So if we had therapies that could have less frequent or ideally one-time dosing, I think when people talk about we want a cure for CF. There are some people that say, well, yeah, a daily dose of something where you then have no impacts of CF. Some people would perceive that as a cure. Other people think, oh no, a cure is really give me one-time treatment where then I never, for the rest of my life, have anything to do with CF. So it's sort of individual perspectives on what cure means. And then drug-drug interactions. One of the most salient ones is antifungal medications interacting with CFTR modulators, but there are certainly plenty other drug-drug interactions through the cytochrome P450 system in the liver. And showing this graphically from the 2023 CF Foundation registry data is not fully out, but they have a highlights data. So this is the most recent, showing that in 2023, 8% of the population was ineligible for modulators based on genotype. There are others who are eligible but not prescribed, which may be for side effects, maybe because people have mild mutations and mild disease, and they're saying, you know, I don't feel like I need this, and then may change their mind if they're pregnant with a fetus that has 2 mutations, as Sylvia talked about. And then, of course, there's disparities in the community. So while the race distribution of the CF population of the 2022 data report was 91.2% white, 3.5% Black or African American, and going down the list on this slide, the distribution among people who are not eligible for modulators is very different, where it's now 75.8% white and 14.1% Black or African American. Hispanic, of course, can bridge across races. So in the registry, about 10% of all patients are Hispanic, and then but of those ineligible is 21.9%. So we have groups that have historically not been treated equally and fairly within the medical system, and then we have something where at the genetic level it's also further widening some of those gaps that we are trying to close. And this is not just a problem within, it's often important for us to focus on the local disparities we have, but even just thinking internationally, there's differences in different countries in terms of what is the distribution of mutations. So this is from the European CF Foundation or Society, their patient registry report from 2022. And so this on the left is the countries, which the fact that they abbreviate in 2 letters really made me scratch my head a bit. I was like, wait, Germany, is that low? And it's like, no, that's Georgia. So we have, but you can see this is showing what percentage in each country is either homozygous or heterozygous for F508del, and then those with no F508del. So you can see, and it's really the further you get east and south within Europe, and I mean actually into the Middle East, because Israel is included here. But you have, that's Georgia, Armenia, Israel, Turkey, Cyprus, Italy. Those have lower rates of F508del. Now, granted, some of those people will have other mutations that are responsive to modulators. But then when we think about this internationally, we don't have the same sort of data for people in Asia, people in Africa. But there's good reason to presume that when we look further away from populations with European ancestry, we're going to see more and more people who are ineligible for modulators. And then also just thinking about what are our international disparities in terms of outcomes with CF even now, which granted part of this could be related to mutations and part of this is related to resources. So the bracket on the left, that's HIC is high income countries, and then LMIC is low to middle income countries. And you can just see the median predicted survival is dramatically different in countries with different resources. And again, this is something that is partly resource based, but could also be partly genetics based in what people are eligible for, even if resources were equal. So then when we're thinking about nucleic acid-based therapies, there's also this question, so, well, how does this compare to other diseases? Could we have the hope, last year there was all the talk about how genetic-based therapies for sickle cell anemia, making up cystic and sickle. But for sickle cell anemia, there was a big breakthrough with approval for a genetic-based therapy. And so how does it compare when we're thinking about CF? And so somebody put this model together, talking about, well, part of it depends on how many genes are mutated and how many organs are affected. So their example here is the transthyretin amyloidosis, where it's basically one cell type, one mutation. And so if you can get something just to the one cell that matters and block that mutation, then you can fix that disease relatively easily. I mean, and relative being the key word, genetic-based therapy is never easy. Whereas something with CF, you have one gene, but affecting many different organs. So now it's, picking and choosing how do we get what's needed to the relevant organs in different locations. And so far, the focus has really been on the lung for the reasons that the lung is the key point of morbidity and mortality in cystic fibrosis, and also from access. Then we can do an inhaled therapy, limit the possibility of systemic side effects while we're assessing the safety and tolerability of these treatments. But with the idea that long-term, we really would like something that's systemically benefiting people with CF. And then their really complex example is if you have cancer that's caused by many different mutations, and not just that, but many different mutations, like with different patterns in different individuals, then it becomes much more complex to manage. So now getting at vectors. So sometimes I think in the plenary yesterday, the speakers were using the term vehicles. But so basically, the question here is, okay, we're trying to get genetic information delivered to cells. How do we get it there? So think about this metaphorically, delivering a message. So say I'm a big fan of Steve Rowe. He's done fantastic work throughout the CF community and has really made huge impacts on the advancement of CF care. So I want to send him fan mail. So I spend weeks crafting my carefully constructed prose to think, how do I want to convey to Steve just what I think about him? And so after those weeks of thinking, I come up with a message. And so now I've got this message, and now the question is, how do I actually get the message to him? So I think, okay, he's at the CF Foundation. He's got to be in Bethesda somewhere. So I'm going to hire a plane. I'm going to print out thousands of copies of this and have the plane drop the message all over Bethesda. But then I realized that that's not in my budget. So I'm going to hire children to grab paper airplanes and throw them around Bethesda and hope that some of them get to Steve. And chances are none of them will get to Steve. They're going to end up in the trash can somewhere as people are picking up the litter that I've contributed to Bethesda. So instead, okay, I'm going to put my message in an envelope, put a stamp on it, and send it. And sorry for anybody under 30, when envelope stamps, this is a thing that used to be used more regularly. But anyway, so then I'm going to put his name on it, and okay, he's probably at some office in the Cystic Fibrosis Foundation in Bethesda, so now I'm going to hope it gets to him. But now it's probably going to go to every office if I've printed out enough copies of this, and so it just kind of gets scattered all over the place. And so for some people, it might be just a useless message, like, why do I care what Dan thinks about Steve? Like, they're going to throw it out. Or if, like, J.P. Clancy gets it, maybe he's going to tear up a little bit, be like, I thought Dan thought more about me. Like, why is he sending something to Steve and not to me? So there's potential either for lack of benefit or harm, even if it's going to the wrong place. So basically, this is the whole idea. We want to get a message to the right place where it's going to be the most useful. And the reality is it might even be more than one place. So it might be that actually I shouldn't have just sent a message to Steve. I should have sent a message to JP as well, and to Kara Fauché, and to Patty Burks, and a dozen other people at CF Foundation, just to find out, okay, who are the people that I really want to get this message to? And so that metaphor kind of now flips into cell types in the airway. So there are many different cells that are lining the bronchial epithelium. And these are some of the key ones. And I think the point here is that different cells have different CFTR expression, so there's some cells where it's much more relevant than others. So you have the basal cell on the left, and the basal cell is really a key part that people think about where, when you look at this structure, if you think about this in 3D, there are also cells that are kind of coming out at us. So those basal cells are sort of buried. They're not right there at the surface to get the message to, but they're also what are thought to function as stem cells. So if you could get the message to basal cells, have it replicating in basal cells, could this be a longer term benefit where now this is not just the immediate impact of the treatment we're giving now, but could this then carry forward as those basal cells reproduce and they're creating the ciliated cells and the secretory cells and the ionocytes going forward? Could you then actually have a treatment that's having a really long-term benefit? But then the other thing you'll notice is down at the bottom here is there's the CFTR messenger RNA per cell, and it really varies. So basal cells have a good amount. Ciliated cells, really not so much per cell. Whereas secretory cells have a lot, and then ionocytes, a more recently discovered cell type, have the highest amount of CFTR per cell. But then also the number of these cells varies by cell type as well. So it's kind of how many cells are there total within each category, and then how important is CFTR in any of the individual cells. So kind of getting that visual of, here's some staining of an airway where the green is the ciliated cells, red is the basal cells. So quite a few of both of these cell types. And then if we look at staining of secretory cells, so these are the main mucus producing cells. So again, quite a few of them, they're larger cells. And we had that, they were some of the 2+ on the prior slide in terms of CFTR production. So a pretty important target. And then ionocytes, far fewer of them, but again, that was the one that was 3+ in terms of CFTR impact. So now when we look at this in another review that's kind of looking at, on the left, how many of these cells are there in different locations. So we have in the central airways and in the peripheral airways. And then on the right, what is their contribution to total CFTR expression? So here we can see, for example, the blue, those are ciliated cells. So there are a lot of ciliated cells. We're getting in the ballpark of half of all the cells in the airways are ciliated cells. But then we get down to their CFTR role is more like 5-6%. So probably not as crucial to get the message to them. Ionocytes, on the other hand, they're 0.5% to 1% of total cells, but then they're in the 7 to 9%. So again, not a huge percent, but they're relative to the number of cells they're pretty significant. And then I think the secretory cells really become a highlight there at 18 to 22% of total cells, but 40 to 58% of the CFTR expression within the airways. So it really kind of gets this idea of, that there are some cell types that we care about more than others when we're trying to get this message to the cells. So now we've identified the cell type. Now, let's say I know Steve's office, and I realize this metaphor might totally break down because even though Steve works for the CF Foundation, he might not even be based in Bethesda. But that's why we do science, because then once you do the experiment, you realize you still can get the message when you thought your vector was perfectly designed. Then you decide, okay, I need a different vector next time. But hopefully I've now targeted the message where I want it to go. And this is using that mock-up of the different cell types, also showing the idea that we don't necessarily need to get the message to every single cell in the airway. I really thought the data at the plenary yesterday that they were showing where it's like they were, that if this genetic message is getting to the cells, it's going to turn the cells red. And then he showed the picture of the lung, and it looks like basically every cell in the lung is red. So that's ideal if you could really get the message everywhere. But this is also showing that, so in picture A on the left, that's supposed to be healthy. So they're showing like kind of the blue. I think it's kind of like has a watery under the sea color feel. So I think it's like, hey, you've got fluid mucus that's moving along. And then the middle pictures are just the CF airway where you now have impacted mucus, non-functional cells. And then on the right, they're showing, okay, well, some of them are having that bluer resolve, they've been appropriately treated with the genetic-based therapies. Some are not functioning, but as long as we get enough function, which we talk about with modulators as well, we don't necessarily need 100% function to have a good phenotypic response. Now, the other complication here is CFTR is a large gene. So if I actually had written a good message to Steve that was 10, 20 pages, it's not going to fit in a regular envelope. I'm going to need a bigger envelope. And so this is part of the challenge with the CF gene is it's 4.4 to 4.5 kilobases, depending on how people like to round off. And so you either need a large enough vector to carry something that's 4,400 to 4,500 bases, or you need a shortened version of CFTR that's still functional. And some of these have been developed and are being applied for some of the trials that are ongoing. And then there's a broad categorization of vectors. There's viral vectors and there's non-viral vectors. And so we'll go into that a little bit more. But potential issues with vectors, especially when we're talking about viral vectors, well, we have immune responses to viruses. So immunogenicity is a problem. So particularly, is this vector similar enough to prior viruses somebody has been exposed to, and do they have an immune reaction to it? This is a big problem. So in the early days after the CFTR gene was discovered, back in the 1990s, there were gene therapy studies that were being done using adenovirus with the idea that, okay, adenovirus is really good at getting genetic information into respiratory cells, but also a lot of people have been exposed to adenovirus before, so you would get immune responses. Or if you were then repeat dosing, even if they didn't have an immune response the first time, you needed to repeat dosing, now you're going to get an immune response the second time. And it might impact both your effectiveness, because now you might just be destroying the thing that you're trying to deliver to the cells. And also, if there's enough inflammation, then you can have severe inflammatory responses. I think probably the most famous case of adverse response to genetic therapy was not somebody with cystic fibrosis. It was actually at the University of Pennsylvania, the Jesse Gelsinger case, where a young man died with a gene therapy product that just led to such overwhelming inflammation that led to his death. And so that's one of those things where people are very careful. It's like, okay, we would want a vector that is going to deliver the information we want to the cell, but without causing that overwhelming inflammation. And so a lot of this is then modifications to the vector. How do we take away the things that trigger adverse responses and yet get the information where we need it to go? So none of these viruses that are being used are the original virus. And so you'll see things where it's like people are using herpes virus for genetic therapy, or adenovirus, well, not so much adenovirus anymore, but adeno-associated virus. So it's this idea where it's like, it sounds weird to patients, like, why are you giving me a virus? And it's like, well, we're giving a modified virus that is to deliver the information that needs to be delivered to the cells. Oncogenesis is another concern. So could this be cancer causing? The biggest concern with these is, so certain types of therapies that I'll go into in upcoming slides do not integrate into the DNA. But some of the idea is that they could integrate into the DNA. And so let's say you have something that goes and it lands right in the middle of a tumor suppressor gene. So that tumor suppressor gene no longer can suppress tumors. So then you could now have the loss of a tumor suppressor gene that you want to have active. And so there's some risk there about could you lead to development of cancer. And then, of course, if it just doesn't deliver the nucleic acid very effectively, then you're not going to have a product that works. Jane Davies and others put together this table, and this, again, is not comprehensive. There are other vectors that could be included, but they have adenovirus, adeno-associated virus, herpes simplex virus vectors, and lentiviral vectors. Now, part of this paper was producing their justification for why they specifically were focused on lentiviral vectors as potentially the most effective in their case. So you can see, and they're making the case for why lentiviral vectors are important. But they get into the idea of large packaging capacity, which adeno-associated virus is the one that most struggles in that regard. The others are much bigger. Lentiviral vectors are ones that tend to integrate more, so there is more concern about insertional oncogenesis, and there are a lot of modifications that have been made to the virus for gene therapy to try to decrease that risk. And then how much inflammation, again, that gets back to adenovirus was not so great because it did produce more inflammation. They all transduce terminally differentiated epithelial cells pretty well. And then the integrating vector. So, of course, the downside was oncogenesis risk. The upside is if you have an integrating vector that's now replicating with the DNA of the rest of the cell, as long as that cell is replicating, you then have potentially functional gene therapy, and especially if you're getting into a basal stem cell, that could then carry on for years and years and years. Now, example of non-viral vectors, there's a dizzyingly long list and so many different variations of this. So there are sugars, polymers, dendrimers, liposomes, lipid nanoparticles. And I think those two, liposomes and lipid nanoparticles, are probably what people have heard the most in terms of non-viral vectors. And in terms of things that are in clinical trials right now, that's what's being used the most. There's silicon nanoparticles. I saw an amazing talk yesterday where they were talking about a process called DNA origami that was just amazing. I mean, they can structure DNA to be in any shape that they want. And so just some really fascinating science goes into this. And so there are just so many different arrays of this. So it's like, okay, we can lump them into the buckets of there's non-viral vectors, but there's so much depth that this certainly could be a 2-hour talk on its own from somebody who really knows all the ins and outs. And then when we get to so now we have, that's the vector. So they're like, what's our envelope look like? But then, okay, what's in the envelope is the other part. So what are the categories of what's inside the vector? And so people talk about this kind of the mutation agnostic. So something that can go to, it doesn't matter what the CF mutation underlying is, because generally what we're talking about here is something where we're giving the entire CF gene, or at least a functional version of the CF gene, if it's one of these modified to fit inside the vector. But we're giving normal information, so it doesn't matter what the prior CF mutation was because we're just giving a normal version. So there's mRNA therapy, there's non-integrating gene therapy, so that's where it does not combine into the patient's DNA. There's integrating gene therapy where it does then integrate into the patient's own DNA. And then there's target-specific mutation, or things that target specific mutations, so antisense oligonucleotides, and then gene editing, which I'm putting an asterisk because there are some approaches to gene editing that could theoretically address most, if not all, mutations. So I'm going to go into these in more detail in upcoming slides. So looking at mRNA, it's relatively straightforward out of all of these because as we go through each type of treatment, it's going to become more complex because you have to get through more barriers to get where you're going. So mRNA translation happens in the cytoplasm. So we don't have to get into the nucleus. As long as we can get inside the cell and then the mRNA is released and can get to rough endoplasmic reticulum, now we can get protein that's made. So basically we have an mRNA protein, in this case in a lipid nanoparticle, that undergoes endocytosis, then escapes the endosome. Now you have mRNA free in the cytoplasm. It goes to a ribosome. You have protein expression. And there's no impact on the nucleus. So both from a safety standpoint, if you're worried, what's going to be the harm if we're having something get into the nucleus, but also from a ease of delivery standpoint, we don't have to get through 2 layers of membranes to get where we want. We just have to get to the cell membrane. Now, DNA is now going a little bit more complicated. And this image becomes more complicated partly because they're including integrating and non-integrating. So if we focus in the middle of the picture is the same for both. So we have a vector that is carrying a healthy CFTR gene, It's then fusing with the cell membrane. The vector enters the airway cell, the capsid is released, and now we want DNA to get into the nucleus, because DNA in the cytoplasm is not going to do us much good. It needs to be transcribed in the nucleus. That's where the transcription apparatus is. So we do have to get through that second barrier to get into the nucleus, so a little bit harder to deliver. And then focusing on the top half, now we have the DNA that integrates into the cellular DNA. So you can see the red DNA gene therapy product that's being given is now incorporated in the double helix of the patient's own DNA. And then healthy CFTR would be transcribed and then goes out into the cell and goes into the same usual pathways for translation in the cell to have functional CFTR at the surface. And then the difference on the bottom with the non-integrating is just saying, okay, well, there is that DNA we delivered is now in the nucleus, but it's not actually incorporated into the double helix of the patient's own DNA before it gets transcribed and translated. Now, antisense oligonucleotides can be, these are the ones that, these are mutation specific. They're single strands of small synthetic nucleic acid sequences. The advantage of them being small, so now we're talking 16 to 25 base pairs instead of 4,400 to 4,500 base pairs. So much smaller. You don't need a big vector to get them in. Often they actually have like a sugar moiety or something on the end, so they don't necessarily need a vector per se. They need to be attached to something that helps them get into the cells, though. But more along the lines of some of the small molecules, like when you think about, oh, we don't need a special vector to get elexacaftor, tezacaftor, and ivacaftor inside a cell. They're just small enough they can get into the cell. But the antisense oligonucleotides form hybrids with RNA, and then they act in different ways, which I'll go into in the next few slides, to target specific mutations. And so really what's been looked at most is potential uses to correct stop codons or splicing errors. And then something that's not relevant to CF, they can also be used to inhibit toxic gain of function mutation. So if you want something where it's like, hey, this is a gene that's creating something bad, we don't want it, so theoretically, okay, let's just block that gene from being produced by using an antisense oligonucleotide that gums up the machinery of transcribing and translating that protein. So so normal splicing, so again, I think this is something everybody's familiar with. So you've got many exons that when we show our central dogma, we often skip the splicing step. But so you've got many exons with introns in between. We splice out the introns, and then it's the exons that then actually go for translation to create functional protein. And so when we're talking about splicing correction, the splicing, the ASO that is currently in clinical trials is the Splicense ASO. And so this is focused specifically on the 3849 plus 10 KB C to T mutation. And so what's happening with that mutation is actually the normal splice sites are actually totally fine. The problem with this mutation is actually there's an extra splice site inside an intron. So there's these 84 base pairs that should not be in the final product that goes out for translation. So now an extra 84 base pairs gets thrown in there. So something that should have been spliced out as an intron is now in that messenger RNA that's going for translation. And the problem is in those 84 base pairs, there's an inappropriate stop codon. So now we've got a protein that is functionally acting like a stop codon. Now the thing is, since there are normal splice sites too, sometimes it splices normally, sometimes it splices abnormally. So this can be a relatively mild mutation for some people if they just happen to have more of the appropriate splicing. So this is why it's a class 5 mutation. It's one of those where you get some normal CFTR through to the cell membrane, but not enough. And so with that, sorry, and then with this, the ASO product is actually just binding at those inappropriate splice sites just to block them. So, because again, the normal splice sites work normally. So now all you need to do is interfere with that artificial signal of a splice site that you don't actually want splicing. And then if you can block that, now you can get to the normal protein. There's also read-through where it's like if you have an early stop codon, you can then design an ASO that binds preferentially to that area of the early stop codon and just then get read-through. So now you can get to, and if you have something that's specific that's binding just to the inappropriate stop codon, now the ideal is you can then have it designed in a way that's not going to block a true stop codon. Because the problem is if you start blocking stop codons all over the place, well, most stop codons we actually want. So it's trying to figure out how do we block the inappropriate ones but leave the appropriate ones functional. And this is actually an example of something that probably is not going to be very relevant because this is a way to, when we have stop codons, we have nonsense mediated decay to break down things with inappropriate stop codons. So then there are some things where using ASOs to block some of the proteins that help break down the inappropriate mRNA. Now we want to, if we block those, well, now we can block anything with an inappropriate stop codon, but then we might start blocking good stop codons as well. Now, gene editing I'm actually not going to go into this in detail because, again, this is just kind of showing there are so many different ways gene editing can be done. But basically, there's, and so I think this is something where we're not that close to human trials for this, at least in CF. But this is something where what method is going to work is going to be variable just based on the results people are seeing over time. But you can do double-stranded DNA breaks where then you could try to insert donor DNA to correct a specific mutation. There's base editing, where instead of doing a double-stranded break of the DNA, you nick one strand of the DNA and then switch it so you go from a CG to a TA pair or an AT to CG pair or GC pair to now try to have a correction of a single point mutation that you don't want, or prime editing, which is kind of doing longer stretches of mutations that you want to fix. And so this is kind of a summary slide of all these different types. So you can have the non-specific integration, which is integrating in the DNA, but it could go anywhere. And then again, that's where you have the oncogenesis concern. So probably something we're going to veer away from. So this picture on the left is showing the star is, that's where F508del would be. So you have your mutation there. Now you just replace this with a gene therapy product that's going somewhere else and you get normal CFTR expression. Then you can have targeted integration at a safe harbor locus. So basically have something that's now set up to go to a location that we know does not cause harm and is not going to create that oncogenesis risk. So now we integrate at that safe space. Well, so at the non-CFTR locus, they have on the right here is like, okay, now we're going somewhere we're not causing harm and we can get that CFTR that's producing itself well. And then site-specific correction, now you can just see that star above exon 11 is gone because now we've fixed the one mutation that's causing CF there in this particular allele. Or targeted integration at a CFTR locus. So this is something that, again, is in that gene editing because we're really targeting. Now we're trying to get something into a specific site that's splicing into the CF gene. What's different about this, so I think this fits more in the gene editing category, but this is the one that could then potentially fix many different mutations because what people have been exploring here is, you can see this example that in that blue bar, it says CFTR 3 to 27. So it's exon 3 all the way up through exon 27. So if there were a mutation in exon 1 or 2, then it wouldn't help those. But anything else, it's essentially just saying, hey, we're just placing the rest of the gene in there. So who cares what's mutated in anything from exon 3 to 27? Because now we've got a normal functioning copy here. And it just leaves the bad function in place. But you basically are ending your transcription and translation at the end of this thing that we've inserted. And so it doesn't matter what mutations are further downstream anymore. So now in the pipelines, so we have the CF Foundation pipeline. I'm only highlighting the things here that are actually in human trials because all the things that are preclinical, there's so many different avenues that are being explored that I don't want to pigeonhole any of the ones in the bottom. But the three messenger RNA studies that are going on right now, there's VX522, there's the Arcturus Lunar CF trial, and then there's RCT 2100, so Vertex, Arcturus, and Recode, all using different variations of lipid nanoparticles, lipid-mediated delivery systems, and there's just a dizzying array of different things you can do to lipid nanoparticles to try to get them into cells. So part of this is all these vectors, even though they sound the same, are slightly different from each other. And so trying to see what's going to be the most effective way to deliver the messenger RNA. And then the 4D710 trial and the SP110 trial, 101 trial, are both DNA via adeno-associated virus. And again, since that's one that's hard to fit the whole gene, it's a modified version of the CFTR gene. And then the SplySense SPL84 trial is the antisense oligonucleotide, specifically for splicing of the 3849. I'm not going to say the rest of it, mutation. And then the CF Trust also has their pipeline. There are fewer things that they're in the UK that they're studying for genetic-based therapies, but they have the lentiClaire. So they are using a lentivirus vector there that is not in the US for clinical trials. And then they also have the VX522 messenger RNA trial. The European CF Society, similarly, they have the Vertex and Recode messenger RNA trials. The Boehringer here is actually just another version of that lentiClaire lentivirus one from the prior slide with the UK Trust. And then choosing studies wisely. So there are so many trials that are potentially out there. And in the US, we have about 1,100 modulator ineligible adults aged 18 years and over with stable disease, with lung function 40% and above, and not implanted. So that's a small group of people to work with. So some of this talk was at the plenary as well yesterday, that it's just how do we design these trials so we can make the trials as small as possible and still get the information we need. And then there's also some thought about how do we expand the number of people who are eligible. And so some of these trials are looking at, do we expand our criteria for people who are on modulators but had a modest response to the modulators, or other issues there. So, and there's just a lot of work that's being done at the CF Foundation, at the European CF Society, and CANACT in Canada, just trying to really vet these trials. Because the thing is, if there are dozens of possible trials out there, but a small population, we want to really try to limit it so the ones that we move forward with doing clinical trials in are the ones that have the best chance of having safety and effectiveness. Now, granted, we could be wrong in the assessments with preclinical data, but that's what we're trying to do, is really pick and choose what are the trials that are most likely to lead to benefit for people with CF. I think I ran a little bit long there, but thank you all for your attention.
Feel free to come to the mic for any questions. We're going to check the app. Thank you, Dan. That was a lot of information. Thank you.
Yeah, that was the example of like too much information to fit in the vector of 30 minutes. So.
No, it was very comprehensive.
Hello, I'm Julia. I'm from Augusta, Georgia. I'm a pediatric genetic counselor. So I have a couple questions. So first, thinking about the future of gene therapy and who's going to be kind of the eligible candidates for what this would look like, I'm assuming age-wise that's going to start with the younger population, because it wouldn't technically, I guess, recover function, but it would continue good function. Is that right?
Yeah, I think when you're thinking ideal long-term, if we had something that we felt was completely safe, then it's sort of like modulators. The sooner you can do it, the better. Mm-hmm. When we're studying them early, most of these trials now are looking only at adults, just because when we're, people have a different appetite for what risk they're willing. It's one thing when somebody's consenting for themselves, saying, yep, there's unknowns here and I'm willing to take this on myself. It's different when you're dealing with a child. So people are really trying to assess safety in adults first before expanding trials to children. But yeah, I think long-term, the ideal would be to have something that we know is safe and effective and can give to a young child.
Okay, that makes sense. And then thinking about these patients that are on these, I'm assuming they have to be on immunosuppression for the viral vector to be delivered, or?
Oh no, it depends on the trial. Some of them are using prednisone just to decrease inflammatory responses.
Okay.
But it's not immunosuppression, like transplant level immunosuppression, and I think it partly depends on the product. Because one thing I didn't get into as much is some of the lipid nanoparticle thing. Those are thought to be not very productive of inflammation. So it may be that depending on what the vector is, we might be able to get away with not even needing to suppress inflammation at all.
Okay, gotcha. And then I'm assuming before and after there's a lot of monitoring that has to go on for these patients.
Yes.
Before and after delivery.
Yeah, that's one of the things that's very different about genetic therapy trials, is even there are trials where it's like you get the treatment once and now we monitor you for 2 years afterwards, and then they extend it and it's like, no, we're going to make it 3 years. And so, yeah, and particularly with lentivirus, because that's integrating, there's some speculation that's like, okay, this might be 15 years of follow-up. And so, which also leads into questions that come up like, well, what if the company goes out of business because they're not having enough benefit? And then who takes up that safety monitoring to see, is there a downstream effect? So that's something that's happening at the level of all the foundations and societies, just to say, these are still the patients we're taking care of and care about, and we want to make sure that we're paying attention to their long-term safety signals, whether the company stays in business or not.
Thank you. Great talk.
Thanks.
I see one question in the chat for Dan, and then one that's been upvoted for Sylvia. And we might be able to get to both of them in our last 4 minutes. Dan, this question asks what your thoughts are on the potential of exon skipping therapies for people with select CFTR variants, like has been done in Duchenne muscular dystrophy.
Right, yeah, and that was the example. Like, I didn't label it exon skipping, but that was this, where was it? That basically what's being labeled here as targeted integration of the CFTR locus is essentially that's exon skipping, that we're skipping all those exons that are not functional, whether it's in this case F508del, but any other mutation by importing just the functional exons 3 to 27. So so there is potential for that. And it could be an exciting way where gene editing could apply to many different people with CF.
Excellent, thank you. And we have an upvoted
somewhat tricky question around echogenic bowel in the third trimester of pregnancy, saying the majority of echogenic bowels are no longer visible in the third trimester. Are there any data on whether untreated fetuses with CF are likely to have visible echogenic bowel in the third trimester?
So echogenic bowel as a general entity is challenging. What I will say is that we know that some echogenic bowel, regardless of whether you have a diagnosis of CF prenatally, postnatally, or not at all, some of it will resolve if you do nothing, which makes the consideration of whether you would consider prenatal treatment another piece to weigh. We suspect that for folks with prenatally identified cystic fibrosis or postnatally identified cystic fibrosis, that the echogenic bowel would be more likely to go on to meconium ileus or meconium plug syndrome or some other clinical manifestation that would be apparent after birth. I think the intricacies of ultrasound and what's monitored at any given gestational age and trimester can vary. But what I can tell you from my own clinical experience is that the finding of the echogenic bowel specifically versus additional abnormalities that can be tracked over time from the second trimester into the third trimester, and whether those resolve, I think are relatively apparent and somewhat linear. If it's resolving, you get some signal that it is resolving, versus if it is not, you get some signal that it is not. So I hope that answers the question.
Okay. Well, thank you to all of our terrific speakers for today and to all of you for attending. Certainly a lot of exciting things in the pipelines.